presentation. And now we have Dr. Kaushik Murali, who is the president of Shankara Eye Hospital Group, which is spread all across India, and the kind of volume Shankara does. See, I'm proud to be an alumnus of Shankara Eye Hospital, and nobody better than Kaushik to speak on. This is a latest advances session. He'll be speaking on what is new in ICAM strategies, community outreach.
Thank you so much, Srini. I think I'm humbled to be a part of this session where I have three teachers who taught me ophthalmology along the years, Dr. JK, you yourself, and Dr. Sumita. Proud to be representing something that is not commonly spoken about when you talk of latest advances, where we are talking about community eye care. So thank you again for considering this important enough for this national symposium. We need to remember that while we sit in this room, we are talking about advanced technology. Our country is considered to be an India and a Bharat in it. Now, I'm not sitting here to make a political statement, but rather to showcase that we need to be aware and remember the diversity that is there in terms of access, availability, and affordability of healthcare. It is not the same for what it is for us as for a majority of our population who will still struggle to get a simple eye examination done or even get a pair of spectacles done. With that in mind, we need to figure out a way how we can enhance our outreach. This is a picture from the last 1 week of some of the outreach activities that have been going on. And this is the India that we should continue to remember while we serve our patients who walk into our clinics every day. What we've done to move on from using a torchlight and a vision chart at the screening camp is to create a handheld application called Service. This is the Shankara Electronic Remote Vision Information System. This is a handheld device that allows, it is available in 7 languages, that makes it easy for our field staff in the states that we currently are present in. They can do a household survey, they can complete their attendance, they can complete their administrative activities, and this allows them not just to share what screening has been done, but also generate a QR code. So most of these are illiterate patients where you tell them that you have to carry something. It becomes a challenge and you want to track this patient from the village to the hospital and back. So they carry a QR printer. This is handed over to the patient. At the hospital level, we are able to kind of analyze what has been happening across all our centers, across all the field workers, and look at how efficient this entire screening has been. This also, when linked to a GIS, helps us create hotspots. So what you see on the map on top is where the household surveys have been done, and the little red and orange specks show you saying that where systemic diseases have actually been identified. This allows more targeted interventions to be carried out in these households. We've looked to kind of also add in a little element where we thought, can we actually get a patient, our field staff, to capture a photograph of the eye using a simple smartphone, and can AI be enabled to actually help them identify what is referable cataract. In this, we are looking at somebody having a visual acuity of say 6/18 or less and still have a cataract and pick it up. This currently we're still working on the algorithm. The sensitivity specificity isn't that great, but it is definitely much better than a torchlight being used. Over the years, what has also changed is our shift in focus from cataract to other systemic diseases. So we partnered with a company called Leben Care to work on an AI solution. Again, look at referable diabetic retinopathy. So we looked at how the image could be classified and a simple AI report that could be generated. We also worked with a couple of school students because when you talk of community outreach, it's not just surgical care but preventive care. But again, we looked at saying that can smartphone images be used to actually detect amblyopia risk factors, and this again is something that we are looking to deploy in the years ahead. Teleophthalmology vision centers have been something that a lot of us in community outreach have been familiar with. Typically, this would involve a Skype or video call consultation where an image is transmitted and the doctor kind of chats with the patient. What we've done differently again is we worked with the University of Bonn and with now Remedio, who took over the company we worked with earlier, and we've looked at layering an element of AI. So here the fundus image is captured, that gets pinged, an AI report gets generated. What you see, those black blotches, are actually hotspots where the ophthalmologist can actually look more closely. And then sitting here in Bangalore for a patient in Virudhachalam, she can actually annotate and say that this patient has a grade of diabetic retinopathy that requires the patient to actually visit a hospital. This makes it much easier for the patient to not unnecessarily travel. what I've tried to showcase to you is a flavor of what is changing in the field of community outreach. Because as ophthalmologists, I'm sure all of us will agree that our eye health should not be defined by where we live or what access or what our socioeconomic status is. So once again, thank you so much for having me as a part of this symposium.
Thank you, Kaushik. That was icing on the cake for this extremely informative national symposium. Namrata ma'am.